perhaps the perfect person to discuss this year in review. And I know personally that it's one of his very favorite topic on any site, year in review. Welcome, sir, to this evening session, and thank you so much to find some time in your extremely busy schedule, I know. So without wasting any more time, I request you to please start your presentation.
Right. Thank you, Dr. Dodal. And in the next 30 minutes or so, I'll present what I call as the year that was. Where do I? Just tell me if my slides are visible to everybody. Is it visible?
Yes, sir.
Right. So the year that was lung cancer, and so without wasting much time, I will start the presentation. So starting with the good news. This is a New England Journal of Medicine article which was published very recently, and this is the effect of advances in lung cancer treatment on population mortality. And as you see over here in the non-small cell lung cancer, the observed incidence in men has fallen down. And so is so very true in women as well. And if you look at the red curve, that is the observed incidence-based mortality has also gone down. It is not so striking in the women population, but it is definitely very striking in the men population. The incidence has gone down. The incidence has not gone down very severely in the women population because perhaps they never took to smoking, and perhaps they have not left smoking because they never took to smoking. As far as trends in lung cancer specific survival is concerned, if you look at the graphs below, the 2-year survival has increased from 26% to 35%, and from 35% to 44% in women, in men and women respectively. As far as small cell lung cancer is concerned, yes, the incidence has gone down. So as the observed incidence-based mortality has gone down, but the survival of small cell lung cancer has not really buzzed much. So both for men and women, the overall lung cancer specific survival has remained same as far as small cell lung cancer is concerned. So one good news is that in non-small cell lung cancer, definitely we are making headway, and the lung cancer specific survivals are increasing. A word on screening. The USPSTE has changed its recommendation for lung cancer screening. Earlier, we had 30-pack years as compulsory inclusion for lung cancer screening, but now it has been reduced to 20-pack years. And also those patients who currently smoke or those who have quit smoking within the past 15 years, because up till 15 years, the smoking history is there, the lung cancer incidence keeps on increasing, or it's responsible for lung cancer. The screening modality is an annual screening with low-dose computed CT scan of the chest. What has been included to make screening more effective is the lung RADS, as we have the PIRADS for breast. Now it's the lung RADS, which dictates whether you need to follow up with a 6-monthly or a 12-monthly CT scan or a 3-monthly CT scan, or whether you need to do a biopsy. So for any lesion which is more than 1.5 centimeter, or any lesion which was detected on the previous scan and has grown and has become more than 8 mm, would require some sort of investigation, that is biopsy or tissue diagnosis, to see whether the cancer has, whether you are dealing with the malignancy or not. It is the CISNET modeling which resulted into the change in the USPS recommendation from 30-pack years to 20-pack years, and changing the age from 55 years as the start age for screening to 50 years. And this is based on not only the screening behavior, the risk factors, but also the diffusion of new treatments. As newer treatments improve survival, the chance that a screening will result into survival advantage also increases. So this CISNET modeling is used, which is based on simulation and analytical models, which explains the outputs as mortality, the quality adjusted life years, wherein the USPSTE changed the recommendation, decreased the age at the start of screening from 55 to 50 years, and from 30-pack years to 20-pack years of smoking history. Now, coming to the newer approaches and the newer publications in early lung cancer. So we have the neoadjuvant atezolizumab plus chemotherapy trial, which is a phase 2 trial, but I think it is really quite practice influencing, and in coming years we'll be using this more. Then in the adjuvant setting, it is the CTONG 1104 trial, which is the overall survival with phase 3 study of adjuvant gefitinib versus chemotherapy. The ADORA study, which is another phase 3 study of adjuvant osimertinib versus placebo in completely resected patients of stage 1B to 3A. And one is the JPANG study, which is the PEM cyst versus binaural vein cyst in completely resected stage 2 or 3A non-small cell lung cancer based on the EGFR mutation studies. So we already know that there has been a few publications in New England Journal of Medicine about the neoadjuvant use of immunotherapy, resulting in a major pathological response rate of around 20 to 27%. And that was the nivolumab study, which was published about 1.5 years back in GM. Now, this is a study of combination of neoadjuvant atezolizumab plus chemotherapy, and the statistical model predicted a major pathological response, which increased from the probability of increasing it from 22% with chemotherapy alone to 44%. When we describe major pathological response, that is less than 10% residual disease should be there in the surgical specimen. And over here, they gave 4 cycles of nab-paclitaxel carboplatin in addition to atezolizumab for 4 cycles. Well, the study was a positive study, although it was a phase 2 study, non-randomized phase 2 study. But the major pathological response, which was predicted to increase from 22% to 44%, became 57%. So they met their primary endpoint, and the interpretation of the study was that the major pathological response, a high proportion of patients could achieve it. And as you can see that the disease-free survival curves were also looking quite increasing. So this is about the neoadjuvant use of immunochemotherapy. This is not a standard of care, but is likely to influence practice in coming years. The next is the updated overall survival data of the CTONG 1104 study. In this particular study, the resected EGFR mutation positive patients were randomized to gefitinib for 2 years versus binaural beam cisplatin for 4 cycles. Well, the overall survival was very similar between the 2 arms. However, the progression-free survival or the disease-free survival was better with gefitinib, that is 30.8 months as against 19.8 months. But the overall survival endpoint was not met. In this particular study, they did post-hoc analysis, and they found that those patients who were on gefitinib and could receive gefitinib for more than 18 months, as was required by the study to complete 2 years. But those patients who stopped before 18 months, they did poorly. But those who could get before more than 18 months, at least could complete more than 18 months, did better. Also, those patients who were on the gefitinib arm and received subsequent TKI did the best. Those who were on the VP arm, binaural beam platinum arm, but received subsequent TKI did the second best. Those who did not receive any subsequent TKI, they did poorly. So it is very important that those who have EGFR mutation positive tumors, they continue to receive TKI in some form or the other. Well, I don't think that this is a very practice-changing study, but yes, for those patients who cannot receive for one reason or the other chemotherapy, gefitinib can definitely be offered for 2 years in resected EGFR mutation positive lung cases. The ADAURA study was in the same line, but slightly different study. So over here, the patients were allowed to complete their set of chemotherapy, and after that, they were randomized to osimertinib versus placebo. So this was not gefitinib versus chemotherapy. This was osimertinib versus placebo. So we expect a larger difference in the survival curves or the disease-free survival curves, because we are pitting osimertinib against placebo and not chemotherapy. Chemotherapy was received by everybody. So once they completed the chemotherapy, they were randomized to osimertinib for 3 years versus placebo, and the disease-free survival curves are in front of you with a very, very impressive hazard ratio of 0.17. That is almost 83% decrease in the risk of progression. And so the median DFS was not reached in the osimertinib arm, but it was 20.4 months in the placebo arm. Even in stage 1B patients, there was some difference which was seen, which were low-risk patients. So even these patients, they did better with osimertinib. Overall survival is not yet mature enough, but if you look at the hazard ratio, it is 0.4, and it is likely to be met as we have more data set and more longer follow-up in this particular study. So the investigator concluded that adjuvant osimertinib should be incorporated into the standard practice for treating patients with stage 1, B2, and 3A EGFR mutated, completely resected lung cancer patients. The last study is a JPANG study in the early lung cancer scenario. It is a randomized phase 3 study of pembrolizumab cisplatin versus binaural beam cisplatin. Before this, we had the TREAT study, which was an Annals of Oncology publication, and it was a phase 2 non-randomized study. But over here, we randomized these patients to pemitic cisplatin versus vinorelbine cisplatin. And what we found is for the EGFR non-mutated population, the recurrence-free survival was in favor of PEMCIS, that is 65.2 months versus 39.9 months for the vinorelbine cisplatin. We know that vinorelbine cisplatin, based on the various previous studies of adjuvant chemotherapy in lung cancer, such as the ANITA trial, the JBR10, and the IALT's trial, vinorelbine cisplatin was the favored chemotherapy regime. But now, for an adenocarcinoma, I think we can safely use PEMCIS with better recurrence-free survival in EGFR non-mutated population. The overall survival was not very different between the two arms. Now, coming to immuno-oncology updates and combination approaches in advanced non-small cell lung cancer. Now, we are talking of advanced non-small cell lung cancer and not the early ones. So, we have got the IMpower 110 study. It was atezolizumab pitted against chemotherapy in the first-line treatment of PD-L1 selected non-small cell lung cancer. We have the updated analysis of the famous CheckMate 227 study, the 3-year update of nivo-EP versus chemotherapy study. We have the CheckMate 9 LA study where nivo-EP was combined with chemotherapy and pitted against chemotherapy alone. And we have a very interesting study, a phase 2 study, CTScape study of a new checkpoint inhibitors called as tiragolumab, which is anti-TIGIT antibody when combined with atezolizumab in PD-L1 selected metastatic non-small cell lung cancer. So as far as the IMpower 110 study is concerned, it was atezolizumab versus chemotherapy in PD-L1 selected population. The statistical testing plan was hierarchical. That is, first they tested for TC3, IC3 wild type population. Then they tested, if that was found to be significant, then they tested for TC2 and 3 or IC2 and 3 against chemotherapy. And if that was significant, then they tested for the entire intention to treat population. So the results for the TC3, IC3 population, that is the primary analysis, yes, the overall response rates was better with atezolizumab as against chemotherapy. It was 38.3 months versus 38.3% versus 28.6%, with the median overall survival reaching 20.2 months with immunotherapy alone. About 38.6% population was found to be TC3 IC3, whereas 60% population was around TC2 and 3 and IC2 and 3. For the 2 and 3 population, the median overall survival was 14.9 months as against 18.2 months with atezolizumab. It is in favor of atezolizumab, but the hazard ratio dropped from 0.59 to 0.72 for the TC2-3 or IC2-3 population. So this was all in all a positive study of atezolizumab as against chemotherapy for the TC3 or IC3 population. That is PD-L1 highly positive. Coming to the CheckMate 227 study, it was a very complex study trying to answer too many questions, but simply put, it was basically stratification of patients to PD-L1 positive versus PD-L1 negative. Anything which is more than 1% is considered positive. Sorry. The PD-L1 positive population, nivo-EP was pitted against histology-based chemotherapy, and nivo alone was one of the arms. In the PD-L1 negative population, nivo-EP was pitted against histology-based chemotherapy, and the third arm was nivo plus chemotherapy. And the primary endpoint was progression-free survival in high tumor mutation burden, which was found to be positive, but even the tumor mutation burden, which was negative, which was less than 10 mutations, also was found to be benefiting from the nivo-EP combination. So this primary endpoint was not really met. But what we have now is, when we compare nivo-EP versus chemotherapy, we find that the median overall survival is in favor of nivo-EP as compared to chemotherapy, but by a very small margin of around 2 to 3 months, with a significant hazard ratio. And for the PD-L1 negative population also, again, so PD-L1 was not deciding whether nivo-EP is working. Irrespective of the PD-L1 status, the nivo-EP was giving 17.2 months as the median overall survival in comparison to chemotherapy. But the most important landmark overall survival analysis for PD-L1 more than 1% and less than 1% was seen over here. If you were a responder at 6 months, that is, you had a PR, then there's 90% probability that you are continuing to survive at 1 year and 70% probability of continuing to survive at 3 years. As against chemotherapy, where the survival rate at 3 years dropped from 70% to 39%. And that is true for PD-L1 positive and PD-L1 negative population both. So if you were having a response at 6 months, any sort of partial remission, then you have 90% probability of surviving at 1 year, which remains at 82% at 3 years with nivo-ip for the population which is PD-L1 negative. But with chemotherapy, that probability drops to 55% at 1 year and then 25% at 3 years. So this is the landmark analysis of this particular study, that the probability of if you are a responder, then your probability of survival at 3 years is typically very, very high, sitting at around 70 to 80%, irrespective of your PD-L1 status. 70 to 80% chance of surviving at 3 years. So how do we take the results of the CheckMate 227 into perspective? So this is a comparative chart that I have shown you over here. So these are the hazard ratios. These are the hazard ratios which you have to take into perspective. So if we were to compare nivo-ip with pembrolizumab or atezolizumab of the IM power 110, these are the hazard ratios. For a population which is PD-L1 more than 50%, that is highly positive, you have an overall survival hazard ratio of 0.70, which is 0.6 or less than 0.6 with atezolizumab. So atezolizumab seems to be the winner arm. And even for pembrolizumab, it is 0.63 for more than 50%. And for all histology, it is around 0.69. But look at the treatment-related side effect profile. The treatment-related side effect profile is sitting at 33% with nivo-ip, which is 12.9% with atezolizumab alone, or sits at around 18% with pembrolizumab alone. So definitely, if you take into account side effect profile, I think atezolizumab is likely to be the winner arm for a highly positive PD-L1 population. For those who are 1 to 49%, we not consider atezolizumab because the study didn't really look at that. But even over here, for 1 to 49%, perhaps it appears that both nivo-ip and pembrolizumab seems to be performing the same. But for the highly PD-L1 positive population, I think atezolizumab is the winner arm because of the toxicity profile and a very impressive hazard ratio that you see over here. That is 0.59, which is not seen with even pembrolizumab. For the population which is, if you were to do immunochemotherapy and see the results of nivo-ip, that CheckMate 227 study, and you try and look at the population of pembro plus chemotherapy for the more than 50%, you have a hazard ratio of 0.42, which is 0.70 with nivo-ip, and with a very significant risk of treatment-related adverse events. So over here, it appears that the pembro plus chemo arm seems to be doing the best. From 1 to 49%, again, pembro plus chemotherapy has a hazard ratio of 0.55, which is around 0.88 with nivo-ip or 0.94 with nivo-ip. So nivo-ip doesn't seem to do well over here. For the population which is PD-L1 negative, again, chemotherapy plus pembrolizumab seems to have a hazard ratio of 0.59, which is 0.62 with nivo-ip, but with more side effects, immune-related side effects. So it appears that pembro chemo seems to be the treatment of choice. And if you were to use immunotherapy alone for a highly PD-L1 positive population, atezolizumab is likely to give you the best benefit, risk and benefit ratio, as far as risk and benefit ratio is concerned. The CheckMate 9LA was another attempt by the BMS to bring nivo-ip plus chemotherapy combination into play. We know that nivo alone doesn't work. Nivo plus chemotherapy doesn't work from the CheckMate 227 arm, or one of the arms of CheckMate 227. But nivo-ip does work. So they thought that let's combine nivo-ip plus chemotherapy and pit it against chemotherapy alone. And they were successful, and they found that the interim updated overall survival analysis showed that the median overall survival is sitting at 15.6 months as against 10.9 months. So is the progression-free survival, and it is true for all sorts of patients. PD-L1 negative, PD-L1 positive, PD-L1 highly positive. For all sorts of patients, the hazard ratio did not really change much. Just look at the hazard ratios, 0.62, 0.64, 0.66, 0.61, very similar. So irrespective of the PD-L1 status, nivo-AP plus chemotherapy is working well as against chemotherapy. But we don't know whether nivo-AP plus chemotherapy is doing better than nivo-AP alone, because that is not one of the arms of this particular study. But yes, nivo-AP and just two cycles of chemotherapy seems to be doing better than chemotherapy. Now coming to the anti-TIGIT antibody. So this was one study which was looking at PD-L1 TPS more than 50%, and they randomized patients to atezolizumab, that is like IMpower 110, versus atezolizumab and tiragolumab, which is an anti-TIGIT antibody. Anti-TIGIT antibodies are basically they inhibit the immune checkpoint receptors expressed on multiple immune cells, including T cells and NK cells, and the NK cell activity by binding to the PVR ligand on tumor cells and APCs. So if you look at the response rate, they are remarkably very good. With atezolizumab, you have a response rate of just 24% in a highly PD-L1 positive population, which increases to 66%. And this is reflected in the progression-free survival, which is not reached versus 4.11 months with atezolizumab alone, but it doesn't seem to be working for PD-L1 negative population. So a phase 3 skyscraper 01 study has been rolled out for patients who are PD-L1 positive with tiragolumab and atezolizumab. So perhaps we are looking at more immune checkpoint inhibitors in the coming years. Now the next phase is optimizing first-line treatment in EGFR mutated non-small cell lung cancer. So we have the FLAURA study, the updated overall survival analysis. We have the ramucirumab plus erlotinib data, the RELAY study, which was a Lancet Oncology publication. We have two JCO publications of gefitinib alone versus gefitinib plus chemotherapy in non-small cell lung cancer, advanced, which are mutated for EGFR. And one is the Tata Memorial study, one is the Northeast Japanese Group 009 study. And a very interesting phase 3 study coming from China, though, and that is interim analysis of first-line EGFR TKI with or without SBRT in patients who have oligometastatic non-small cell lung cancer, which are EGFR mutated. The FLAURA study is an old study. We know that it was randomization to osimertinib versus gefitinib or erlotinib, that is first-generation EGFR TKI, and the crossover was allowed. Patients who had confirmed progressive disease and had T790M mutation, they could go on to receive osimertinib in the control arm. And the overall survival analysis is over here, and we know that that was found to be significant with a hazard ratio of 0.79, and the overall survival crossing the median overall survival of 3 years, that is 38.6 months as against 31.8 months. The time to subsequent treatment was also prolonged by osimertinib, that is 25.5 months versus 30.7 months. The next is the RELAY study, that is addition of ramucirumab to erlotinib and looking at the progression-free survival. And the progression-free survival was 19.6 months with ramucirumab plus erlotinib versus erlotinib alone. And that is the reason it is included as category 2A or 2B recommendation in the NCCN guidelines. Another important study was the combination of the first generation EGFR TKI plus chemotherapy versus EGFR TKI alone. And this was a positive study with a median progression-free survival of 20.9 months as against 11.7 months, the NEJ009 study. And the median overall survival was also found to be statistically significant, 38.8 months versus 50.9 months. Mind you, 38.8 months was the median overall survival in the FLAURA study, that is the osimertinib study, which is being reached in the gefitinib group over here. But mind you, this is a Japanese population which seems to have exquisite sensitivity to EGFR TKI. So we can't really look at the numerical number of 38.8 months. So the authors did conclude that this seems to be quite practice changing, that you can combine chemotherapy and combine it with EGFR TKI. The same results were reflected in the TMS study by Dr. Norona, and over here the progression-free survival also improved, as is seen in this waterfall plots, as is also the median overall survival, which was drastically improved in this particular study, and it became a JCO publication. The phase 3 is a SENDAS study, which is including EGFR TKI with SBRT in an oligometastatic EGFR mutated population. And this was a positive study which increased the progression-free survival from 12.5 months to 20.2 months, and also the overall survival from 17.4 months to 25.5 months. There is good ground to add SPRT to all the sites of oligometastatic disease in EGFR mutation positive patients. And this suggests that further evaluation of upfront aggressive local treatment to metastasis and diagnosis in a larger phase 3 study can be contemplated based on the interim results of this particular study. This was updated in the ASCO 2020. Now, the last part of this presentation is the ever-increasing targeted therapies and the new kids on the block. So I'll discuss about capmatinib, that is the geometry trial, and we will discuss the savolitinib with osimertinib, the TETON study, the AMG 510 and the MRTX 849 in the KRAS mutations, and I'm sure that you would have seen the NEGM latest publication on AMG 510, which got an accelerated approval for this particular drug, and entrectinib, pyrotinib, and trastuzumab deruxtecan, and the RET inhibitors such as selpercatinib and pralsetinib. So the capmatinib is a MET exon 14 inhibitor, and it also works on the MET amplified non-small cell lung cancer. It is an NEGM publication, and it did show that the overall response rate sits at around 67.9% for the exon 14 skipping mutation if they are not pre-treated, and it's around 40.6 months in the pre-treated population. Whereas in the MET amplified, that is gene copy number more than 10, mind you, the amplification definition is gene copy number of more than 10 and not otherwise. In the untreated population, the overall response rate sits at around 40% and is around 30% in patients who have been previously treated. Mind you that MET amplification occurs more commonly in males and smokers, whereas MET exon 14 skipping mutation occurs more commonly in females and never smokers. So it's totally reverse. The MET amplification is seen more commonly in smokers and males, whereas MET skipping 14 mutation occurs more commonly in females and never smokers. Another drug called as tipotinib is also works in MET exon 14 skipping mutation. Very impressive for us waterfall plot with a median progression-free survival of around 11 months to 8.5 months, depending whether you have detected this on a liquid biopsy or a tissue biopsy. We know that one of the mechanisms of resistance to osimertinib is MET amplification, and this is a study where EGFR mutated population were assessed for MET amplification and then were offered osimertinib plus savolitinib. Savolitinib is a MET inhibitor like tipotinib, and capmatinib is a MET inhibitor of MET amplified tumors. And in this particular study, depending on whether they have received third generation EGFR TKI and whether they have a T790M mutation or not, you can see that the waterfall plot shows excellent responses with osimertinib in combination with savolitinib, and this results in impressive progression-free survival. Depending on their disease profile, it can range from in excess of 8.5 months to almost 6.5 months, depending how much pre-treated they are. Entrectinib is a new ROS1 fusion positive inhibitor of non-small cell lung cancer, and it has been specially designed to penetrate the brain. As you see in these waterfall plots, many patients achieve complete remission with entrectinib, those who have ROS1 mutation positive, with a very impressive progression-free survival in excess of 18 months. And even CNS responses, which are quite complete. We know that before this, there was only crizotinib, which was there with us, and crizotinib has lesser brain penetration, but entrectinib has superior brain penetration and can achieve complete responses in the brain as well. So this is another new kid on the block. Pyrotinib is a HER2 inhibitor, and this has been tested in a phase 2 study in HER2 mutant advanced lung cancer, with overall response rate sitting at around 30%, and quite deep responses can be registered, and a median progression-free survival of around 6.9 months is particularly seen with pyrotinib, which is in HER2 mutant lung cancers. The Destiny Lung 01 study is a trastuzumab deruxtecan study which had two arms. Cohort 1 is HER2 expressing tumors, and cohort 2 is HER2 mutated tumors. Mind you, these are two different cohorts, And over here, we are discussing the HER2 mutated tumors and not the HER2 upregulated tumors. So HER2 mutated tumors, you can see that the response rates are sitting at around 60%. Very impressive, as is true for trastuzumab deruxtecan. It's doing the same magic as it did in stomach cancer, as it did in colorectal, and as it did in breast cancer. The progression-free survival is not touching the median line. So is the overall survival. So very impressive overall response rates, very impressive progression-free survival and overall survival. Unfortunately, the drug is not available with us and is way too costly. AMG 510 is a novel KRAS inhibitor and it targets the G12C inhibitor. It's a G12C positive solid tumors, and it did find that the maximum tolerated dose is 960 milligram per day and results into responses in KRAS G12C positive solid tumors in about 50% of the patients. The drug seems to be tolerated very well. Look at the grade 2 toxicities, hardly any. It can result into some elevation of liver enzymes and some cheilitis, some hyperkalemia, but more or less the drug seems to be very well tolerated. And this was presented in the ISMO meeting and has become an NEGM publication. Another drug called as the MRTX849 is another drug which targets the same G12C KRAS mutation, and you can see that these CT scan films are there. It shows that remarkable responses can be achieved, almost resulting into complete remission with these new drugs. This particular company is also trying to make other inhibitors such as KRAS G12D inhibitors and other multi-kinase inhibitors, and they are likely to be on the way. Pralsetinib is called as Blue 667. It's a RET fusion positive non-small cell lung cancer inhibitor, and this is given in the dose of 600 milligram BID and or the 400 milligram OD in the dose expansion study. It results into very remarkable responses and quite a significant number of complete responses, as you see over here, and with very impressive forest this waterfall plot with remarkable CNS activity. So the overall response rate sits at around in excess of 60% with very good CNS responses. So that is one drug called as pralsetinib. Other drug is selpercatinib, which is also for RET mutated non-small cell lung cancer. Again, very impressive responses in excess of 60 to 70%, some complete responses and remarkable CNS activity in RET mutated non-small cell lung cancer. The toxicity seems to be about some patient having an increase in SGOTPT, some patient having peripheral edema, some patient having prolonged QT interval, but overall seems to be doing well with about 14% patients to around 20% patients suffering from some grade 3 or worse toxicities. With that, I thank you for your kind attention, and I think it was about 30 minutes or so.
Thank you so much, sir.
Pleasure.
And as always expected, hearing review is always excellent from listening from you. I really don't understand how can you remember so many trials with so much data and precision. Lot of questions. If you allow me,
there are tremendous questions.
So I think, sir, you can select the questions as per your understanding, and I think I should leave it up to you.
So, Dr. Vinod has asked something. I don't know what he's referring to. An article about which drug?
So, Dr. Vinod has the first question. Mortality did not reduce in female, as we know they are more.
He's referring to the NEGM paper of
yes, at the beginning
of lung cancer mortality.
Yes.
The mortality did not reduce in female. It did reduce in female as well. For non-small cell lung cancer, not for the small cell lung cancer, but yes, it did reduce in the non-small cell lung cancer. And in small cell, there is no targeted therapy. So I think it did reduce. If you look at the survivals, the survival lung cancer specific survivals have increased. The incidence has not dropped down in females. because perhaps we always read that more females have taken to smoking as compared to more males stopping to smoke, right? So, and never ever there was less number of, obviously females used to smoke lesser, but since they used to smoke lesser, the cancer incidence was obviously lesser. But the drop in the incidence is definitely seen, but lesser intense because their incidence was lesser. So if you have a lesser thing, you'll find the change which is lesser. But definitely the lung cancer specific survival has increased. Should we use gefitinib in the adjuvant setting? Why not? I already started using it. But as you see the ADORA study, you can give chemotherapy and then put the patient on gefitinib. You're not giving osimertinib, because in the osimertinib study, they completed the chemotherapy and then randomized to osimertinib for 3 years versus placebo. So in the CheckMate 227 PD-L1 positive, Nivo looks good compared with Nivo AP. So Nivo did not look good as compared to Nivo AP. The difference was very, very small. If you look at BMS, the BMS never promoted Nivo alone as a treatment option in PD-L1 positive patients upfront. They never promoted Nivo alone. They are obviously promoting only Nivo EP. If you look at Nivo plus chemotherapy, the hazard ratio is not significant in the PD-L1 positive population. Irrespective of the PD-L1 status, it is Nivo EP, and they will keep on promoting only Nivo EP. For Nivo EP landmark analysis going with chance of long-term benefit if responded by PR by 6 months may be misleading. The combination also lead to higher progression. There is no doubt. So if you are a responder, so it is a very biased. What Dr. Vinod is saying is right. It's a very biased outcome because only if you respond, then only you are likely to hit that 80% mark. But there is a chance that you may hyperprogress. So you have to choose your patient very carefully. That's the reason they rolled out the CheckMate 9LA study where they combined Nivo EP with chemotherapy. But I don't know how many takers would be there. Dr. Rajiv Bhattacharjee has asked FLAURA PFS benefit, but no OS benefit in Asians and L858R. Why? So I think you are looking at a subset analysis, and we don't really know whether this subset is powered enough to look at their survival benefit. And obviously, if you look at a smaller subset, the survival benefits keeps on getting diluted. And you have to also take into account that all these patients upon progression were offered osimertinib. So the overall survival analysis is likely to get diluted anyways. So is it okay to now to use TKI along with chemotherapy in EGFR mutated non-small cell lung cancer? Is it okay now to use TKI along with chemotherapy? I think so. It's Dr. Aman Chaudhary has asked whether we take the NEJ009 study and the TMS study into practice. But I would discuss these findings with the patient, and I would definitely offer if they cannot afford osimertinib, that should be the second standard of care. I would definitely offer TKI first generation EGFR TKI with chemotherapy. But obviously, the premise of using an EGFR TKI is to avoid chemotherapy. But I'll definitely discuss the results of this study and see if they would like to take it. How to treat EGFR mutated patient with MET amplification or exon 14 skipping mutation at baseline? Well, there is no correct answer to this particular question because we don't have any data set. Rather, we don't even have MET inhibitor in our own country. So you don't really have an option of treating them, although one can think of combining osimertinib with crizotinib as a MET amplification inhibitor, but that's a weak inhibitor. I would treat them with only EGFR targeted therapy. And if they were to progress, perhaps I can treat them with MET inhibitor at that point in time. As a matter of fact, we are rolling out capmatinib study at our own center in Polo, Delhi. And that study will start very soon. So we can offer capmatinib to your patients in case they are found to be MET amplified, MET mutated or MET amplified. So entrectinib study is a first-line study, definitely, and it's generally ROS1. You'll never find a phase 3 study. We don't really expect a phase 3 study. The question asked is, how does trastuzumab deruxtecan work in HER2 mutated cases if they are not amplified? I don't know the answer to this. We don't know. It just works. Maybe there is very meager expression of HER2 and it gets internalized because the payload with trastuzumab deruxtecan is very, very strong of irinotecan of SN38. And even in lightly mutated population, perhaps there is some expression of HER2 which is beyond our capability to test, and it gets internalized and causes a greater cell kill. So this is my explanation, but I don't really know the correct answer to this. Yes, so the soratisib is the same as AMG 510 to the best of my knowledge, and that is a new KRAS inhibitor. Yeah, it is AMG 510 by Amgen, Dr. Vinod Singh. So I think that is the continuation. Don Cabra only commented that it's an excellent overview.
At the end, we have two more questions, sir, so she's Dr. Ritu. What is your current practice in the following setting? EGFR positive metastatic adenocarcinoma in first line treatment, metastatic squamous cell carcinoma first line, PD-L1 positive.
Sorry, once again.
So first line treatment in EGFR positive metastatic adenocarcinoma and metastatic squamous cell carcinoma PD-L1 positive. Your first line treatment.
The first line for EGFR mutated population will be osimertinib. That is category 1 in the NCCN guidelines. If the patient cannot afford osimertinib, then I would definitely discuss the study of NEGA 009 and the TMS study to give them first line EGFR TKI and chemo. Coming to the question of squamous cell carcinoma advanced, I usually would offer them immunochemotherapy combination because that is the best combination to be given with a very impressive hazard ratio of 0.65, irrespective of the PD-L1 status.
And the next question from Dr. Ritu is adjuvant treatment post-surgery in non-small cell lung cancer.
Sorry?
Adjuvant treatment in post-surgery setting for non-small cell lung cancer.
Adjuvant setting in resected non-small cell lung cancer.
Yeah, I think maybe PD-L1 positive resected lung cancer.
No. Over there in the resected lung cancer, PD-L1 status in the adjuvant setting has no meaning as of now. So you would treat, if they are EGFR non-mutated, I would treat them with simple chemotherapy, PEMSIS or PEM-carbo for 4 cycles. Adenocarcinomas.
Right, sir. And the last question from Dr. Vinod, is enterectinib available on compassionate basis?
I'm not sure. The last ROS1 patient is still doing very well on crizotinib and has not progressed. So I never looked up whether enterectinib is available on compassionate basis. So once I have a patient like that, I'll definitely try to know whether enterectinib is available on compassionate basis or not.